Students, I welcome you all to Obstetrics and Gynecology with Mackler. So, in the last module, when we discussed about the treatment algorithm of cervical intraepithelial neoplasia based on the reports of colposcopy, I mentioned about two terms, right? So, one was cryoablation and the other was excisional procedures. So, as far excisional procedures are concerned, we have two things, right? One is going to be loop electrosurgical excision procedure, and the second one is going to be the conization or the cone biopsy. The conization and cone biopsy has been already discussed in the previous module, and this loop electrosurgical excision will be discussed in the subsequent module. But in this module, we are going to give our entire concentration towards the cryoablation. So let's start with the topic. So what do you mean by cryoablation? So before starting with cryoablation, please make note of these two things, right? So this cryoablation is a minimally invasive procedure. It is a minimally invasive procedure, and most importantly, it is an OPD procedure. Unlike the conization or the cone biopsy, where we have to do that procedure in the OT theatre under anesthesia, and admission is definitely required for the patient. But unlike this conization or cone biopsy, in cryoablation, it is an OPD procedure, right? The entire process will be done in 15 to 20 minutes, and it is a minimally invasive procedure. Is that clear? Yes. So what do you mean by cryoablation? The word cryo stands for cooling, right? Cryo means cooling. And what do you mean by cooling? Freezing, right? So cryo stands for freezing. And ablation means to destroy or remove something. Here we take ablation as destroy. So what do you mean by freeze and destroy? So it is actually by the process of freezing, you're going to destroy the abnormal cervical tissue. Is that clear? We know that cryoablation is a treatment of choice for cervical intraepithelial neoplasia. For the treatment of cervical intraepithelial neoplasia, whatever cervical tissue is abnormal, you are going to destroy those abnormal cervical tissue by the process of freezing. And this is done with the help of a cryoprobe. So this can be done with the help of what? This can be done with the help of a cryoprobe, or this can be done with the help of cryogenic liquids. So this can be done with cryoprobe, or this can be done with the help of cryogenic liquids. So cryoprobe is basically a probe, right, which at very low temperature you're going to introduce inside, and this cryoprobe at very low temperature is going to cause freezing, and it is going to eventually destroy the abnormal cervical tissue. Similarly, if you're going to take cryogenic liquids, the most commonly used cryogenic liquids are carbon dioxide and nitrous oxide. So carbon dioxide at a temperature of minus 78.5 degrees Celsius and nitrous oxide at a temperature of minus 65 degrees Celsius, right? So this at low temperature, this will also cause freezing. Eventually, it leads to destruction of the abnormal cervical tissue. Now, you may have the doubt that how come freezing is going to cause destruction of the abnormal cervical tissue? It is because of the fact that when you are going to introduce the cryoprobe or the cryogenic liquid at very low temperature, what is going to happen there is cryonecrosis. That is, this freezing is going to cause necrosis. We all know that necrosis means cell death. So this freezing is ideally causing cell death. But how? Because it is going to cause crystallization of the extracellular and intracellular water. So the freezing is going to cause crystallization of the extra and the intracellular water. So this crystallization is going to result in cryonecrosis. Freezing, you're going to do the process of freezing, but this freezing is going to result in crystallization of the intracellular and extracellular water, and it is going to result in necrosis or cell death. So basically with the process of freezing, you're going to bring about the cell death, right? Okay, so let me discuss the procedure of cryoablation for you. So when we call that freezing, you're not going to just freeze and remove the probe or the liquid, right? You have to do some procedure, and that is freeze-thaw cycle. Freeze-thaw cycle. thaw is a state of reversal of freeze, right? You're going to freeze, and the state of reversal from freezing is called as thawing. So freeze and then release and then freeze, you have to release. So 2 cycles. So first you will freeze and then you will release, and then you will freeze and then you're going to release. Release is nothing but you're going to come from a state of reversal of freezing. So this freezing will be for a period of 3 minutes, followed by thawing for 5 minutes, followed by freezing for 3 minutes and thawing for 5 minutes. So this thawing has to be very slow and it has to be very prolonged. Only then it will bring about proper cell destruction. If the thawing process is going to be so rapid, it is going to result in cell survival. So the ideal procedure of cryoablation is done only to destroy the cervical tissue. So for proper destruction of the abnormal cervical tissue, you have to do this freeze-thaw cycle twice. So 2 cycles of freeze-thaw cycle, where freezing followed by thawing, freezing followed by thawing. So 2 cycles are repeated, and this thawing has to be very slow and it has to be prolonged in order to bring about proper cell destruction. Is that clear? So cryoablation is a process where you're going to destroy the abnormal looking cervical tissue with the help of process of freezing. So this freezing can be done with the help of either a cryoprobe, where you're going to introduce the cryoprobe and bring about freezing, or with the help of cryogenic liquids. This liquid is going to cause freezing. In other terms, it is going to cause crystallization of the intra and the extracellular water, which results in cell death, that is cryonecrosis. Right? And the procedure goes like freeze-thaw cycle, and the cycle has to be repeated twice. So 2 cycles of freeze-thaw cycle. Now, before discussing about the indication, let me tell you one thing, right? Let's take an example that this is the probe. So this probe is going to cause freezing of the cervical tissue about 7 to 8 millimeter distal to the probe. So let's say that this is going to be the cryoprobe, right? This is the cryoprobe, and this probe is going to cause freezing of the abnormal cervical tissue about 7 to 8 millimeter distal to the tissue. So 7 to 8 millimeter distal to the cryoprobe, it is going to cause freezing, that is crystallization of the intracellular water. So if someone asks you how many millimeter distal to the cryoprobe it causes freezing, 7 to 8 millimeter distal to the cryoprobe, it causes freezing, right? Okay. So now we'll discuss about the indications. So cryoablation is the treatment of choice for cervical intraepithelial neoplasia type 1. And when type 2 and 3 are concerned, if the indications are met for cryoablation can be done. But the treatment of choice for cervical intraepithelial neoplasia type 2 and 3 is excisional procedure, that is LLETZ or LEAP. Is that clear? Okay. So what are the indications for cryoablation? First thing is that since this is a treatment of choice for cervical intraepithelial neoplasia, therefore no invasive cancer should be present. So no invasive cancer should be present as the first indication, and the second indication is that there should not be any glandular disease. What are glandular diseases? Glandular means columnar type of epithelium which is present in the endocervix. And what are the conditions affecting the endocervix? Adenocarcinoma in situ. So therefore no glandular disease should be present, and the transformation zone should be visible, and if at all any lesion is present, the lesion should be present in the ectocervix. The lesion should not extend inside the endocervix, right? So the transformation zone should be visible, and if at all any lesion is going to be present, that lesion should be entirely in the ectocervix and it should not extend into the endocervix. If the lesion is visible in the type 1 transformation zone. What is type 1 transformation zone? So the third and the fourth points are same to each other, because type 1 transformation zone is where the transformation zone is entirely visible and it is in the ectocervix. There is no endocervix component. So the lesion should be in the type 1 transformation zone in order to do cryoablation, and endocervical curettage, if done, it has to be negative. So endocervical curettage should be negative. Only then you can proceed with this cryoablation, right? And definitely this lesion should be limited to only 2 quadrants of the cervix. It should not extend more than 2 quadrants of the cervix. So what are the quadrants of cervix? This is quadrant 1, 2, 3, 4. So definitely the lesion, if present, it should be present only in 2 quadrants of the cervix. Is that clear? Okay. Now, what are the contraindications? Ideally, opposite to the indications or the contraindication, right? So, if any invasive cancer is present, so definitely the treatment will become, if invasive cancer is present, the treatment will become hysterectomy, radical hysterectomy, followed by radiotherapy. So, therefore, no invasive cancer, no glandular disease such as adenocarcinoma should be present. So, what are the contraindications? If at all a patient is having invasive cancer cervix, a patient is having adenocarcinoma, HIV positive female with cervical intraepithelial neoplasia, because in any HIV patient there are increased chances of cervical carcinoma when compared to any normal female in the population. HIV patients are even more prone to develop cervical cancer. So for that reason, HIV positive female with cervical intraepithelial neoplasia, we are not going to do any cryoablation, right? Okay. And failure of previous treatment. Let's say, for example, a patient who is a known case of cervical intraepithelial neoplasia, you have done cryoablation in that patient earlier, and during the follow-up, you came to know that cervical intraepithelial neoplasia is present. So it tells that there is failure of the previous treatment. So in cases of failure of the previous treatment, it should not be repeated again, and it should be followed up only with the next procedure. So if cryoablation is going to fail, the next is going to be excisional procedure, and we all know that the excisional procedures are loop electrosurgical excision, right? And then we have the conization, right? Yes. So what are the pros and cons? So what are the advantages and the disadvantages of this procedure? The advantage of the procedure is that it is a minimally invasive procedure, and it is an OPD procedure. There is no need for any admission. The disadvantage is that the patient will have persistent watery discharge after the procedure. So the disadvantage is persistent watery discharge. Since the process of cryoablation is ideally freezing, therefore the patient will have persistent watery discharge after the procedure. So this is the disadvantage of cryoablation. So how are you going to follow up this patient? So let's say, for example, a patient came to me, right? A patient came to me. Right? So let's say, for example, a 28-year-old female, she came to me with particular symptoms, right? So now I'm going to do colposcopy in her. While I'm doing the colposcopy, the report comes to me as cervical intraepithelial neoplasia type 1, and as cervical intraepithelial neoplasia type 1 has the maximum chances of spontaneous regression in the next 2 years, I am going to ask her to follow up after 2 years. So after 2 years, if the cervical intraepithelial neoplasia type 1 is present, then I have to do the treatment, that is cryoablation, right? So a 28-year-old female, she came to me with complaints of bleeding per vaginum, to be even more particular, postcoital bleeding, right? So as a result, I'm going to put a speculum examination. On speculum examination, I was not able to see any lesion, right? And then I followed up with pap smear, and in pap smear, I got a report in order to confirm that I did a colposcopy, and in colposcopy, the report comes to be cervical intraepithelial neoplasia type 1, and since it is CIN1, it has maximum chances of spontaneous regression in the next 2 years. So after 2 years, I'm asking her to come again, and I came to see that the cervical intraepithelial neoplasia type 1 is present even after 2 years of follow-up, and now it is high time I have to take some decision. So I'm going to do cryoablation in that patient. So after that, after 12 months, I have to follow up this patient. So you have to follow up this patient with HPV DNA testing. Why HPV DNA testing? Because HPV DNA, human papilloma virus, is the most common cause of cancer cervix among all the risk factors, right? So for that reason, and WHO tells that the HPV DNA test is even more effective as a screening test for cancer cervix, right? So irrespective of whatever treatment you're going to do in any patient, after the procedure is done, you definitely have to resume the screening for cancer cervix. So like that, in this patient, after 12 months, I have to resume the process of screening for cancer cervix, and I'm going to do HPV DNA testing. Is that clear? I hope it is very clear. And the most important question is that, which is the most common age group for cancer cervix? The most common age group for cancer cervix is, the median age is 50 years. Right? The median age is 50 years. And the most common complaint of cancer cervix is irregular bleeding. To be even more specific, it is postcoital bleeding after having coitus with a partner. Postcoital bleeding. Most common type is going to be squamous cell carcinoma, which arises in the ectocervix, and the adenocarcinoma, which arises from the endocervix. Now, you may have the doubt that when I have to start the screening in any patient, so we ideally have two guidelines, the American College of Obstetrician and Gynecologists and WHO. So the ACOG tells to start the screening from 21 years of age. But WHO tells that to start screening in any patient from 30 years. 30 to 49 years, but ACOG tells you have to start the screening from 21 years of age in any patient. So if a patient is going to come to you with such complaints, let's say for example, here we had a 28-year-old female, right? The cancer cervix is said to have a bimodal distribution, but the median age is around 50 years. But then any patient can come to you with any complaint, since the cancer cervix is the fourth most common type of cancer to occur in females, right? So if a female is going to come to you with specific complaints such as postcoital bleeding, irregular bleeding, and you have to do the initial evaluation, and if she is a 28-year-old female, she is belonging to the reproductive age group. So first do the UPT, urine pregnancy test. If it is going to be negative, follow up it with the speculum examination. If on speculum you are going to see any abnormal lesion, please take a punch biopsy. If there is no lesion, you can't take anything, then do the screening test, that is pap smear. Based on the pap smear report, you can't take any decision. So keeping in mind the pap smear report, let's say for example in this patient the pap smear report comes to be low-grade squamous intraepithelial lesion. So low-grade squamous intraepithelial lesion corresponds to CIN1 of the colposcopy. So definitely with the screening test we can't take any decision. So you have to follow up it with colposcopy. In colposcopy, the report comes as CIN1. And as we discussed the algorithm, any patient with CIN1, wait for 2 years, follow up. If the CIN is present beyond 2 years, do the treatment, that is cryoablation. If the indications are properly met for cryoablation, after cryoablation, follow up after 12 months with HPV DNA testing and resume the screening in that patient till the said years, right? And once the screening comes to be negative for 2 consecutive testing, you can stop the screening for cancer cervix in that patient around 50 years. So this is all about the screening for cancer cervix in any patient, followed by the diagnostic test and what are the treatment based on the reports of colposcopy. So in this module we discuss about the cryoablation. In the next module we'll be discussing about the excisional procedure, that is loop electrosurgical excisional procedure, right? I hope it is very clear for you. In case if you feel there is any query for you, please write to us in the Mackler handle, either in the Instagram or the Gmail handle. We will write to us as early as possible. Thank you.